All ask members. So nice to see you all. Today we have a very important topic to be discussed. That is uh, that is titled as failed ACL reconstruction. So in brackets we have revision. So essentially, I think we are going to be talking about primary ACL which has failed and how you manage it. It's a very important topic because uh, it's a very important topic because we have a very good number of people doing a huge number of ACL reconstructions nowadays, and the number of cases also have increased essentially because more people are into sports than what it used to be some decades ago, both leisure and in competitive levels, professional, amateur, and leisure sports. So the more number of surgeries you do, you obviously expect a more number of complications and failures. So I think this topic is very relevant for today, and good of Sujit to have chosen this topic. So shall we start now, Sujit? All of your
Yes, let's go ahead.
yeah. So Prince,
Yeah, sir.
let's start with you.
Yeah, very good evening. Can you see my screen?
Yes, Dr. Prince.
Yeah.
Good evening.
So you can see my PPT, right? So as Schiller sir told, so what we see is only the tip of the iceberg. So there's a 400% increase in youth ACL tears over the past decade, and the peak incidence is sadly seen in high school children. And hence the number of ACLs are increasing, tears are increasing. We can expect a increase in incidence of a revision also. So why this is important? Why we want to know the failures of the graft, the causes of failures of the graft? It's very important to prevent the future prevention of ACL failure, and more importantly, revision ACL reconstruction consistently has got worse outcomes than primary. So it is very important to prevent the failure of your ACL graft. So how do the ACL fail? There are mainly four reasons. We can group it into four groups. The most important is the technical factors, then a new trauma, biological failure, and finally the patient-related issues. So the most of the data I'm going to present from the MAS study. MAS study is a multi-centric ACL revision study group. So they are it's basically a prospective longitudinal cohort. 83 institutional review board approved surgeons from 52 sites participated in the study. 1,200 patients were enrolled, and they have got a minimum of a 2-year follow-up. So what are the reasons for failure? Coming to the epidemiology, the most important and the most common reason is a technical failure. It may account up to 75%, and among the technical failure, more than 60% are a femoral tunnel malposition. So it's very important to know that the femoral positioning, your tunnel positioning is very important, more than the tibial footprint. So the next important reason is a repeat trauma, and the least important is a biological failure, and the combined reason constituted around 20%. So when you are evaluating a ACL failure after the reconstruction, there are three things: history, the clinical examination, and the imaging studies. So history, one of the most important thing is the time since last reconstruction, whether the failure has occurred within the first 6 months of surgery or it has occurred after 1 year. So if it has occurred less than 6 months after the index surgery, that points towards a graft incorporation failure. If it has failed 1 year after surgery, that points more towards a repeat trauma rather than a technical failure or a graft incorporation failure. So if there is a history of a rehabilitation facility, if the patient's complaints of a decreased range of motion, lack of a complete extension or flexion, that means you have put your tunnel in a wrong position, which has prevented a full extension or a flexion, and ultimately it resulted in a stretching of the graft and the failure. So a full functioning interlude precludes any technical failure or a graft incorporation. So the most common reason may be a repeat trauma. So giving way, the patient will know whether it's just a traumatic injury or an extrahepatic injury. after the ACL reconstruction. So physical examination is very important. You always have to look for associated injuries. A dial test will tell you about a posteromedial and a posterolateral corner injuries. A pivot chest more than two that is going towards associated injuries like a meniscal tear, a ram lesion, or a root tear. And a posterior drawer will tell you about a posterior cruciate ligament injury. And more importantly, you need to look for a varus or a valgus instability. And the effusion usually may point towards an infection. So the imaging studies will be dealt in detail by the next speaker. So I'm going to the technical failure, which we all can prevent. So this is a preventable thing, which we all should know. So this is a very important picture. I think this is taken from Mercer. I think all of you can see the picture. So the reason for our technical failures, it could be a tunnel position, it could be a fixation issue, and it could be a failure to recognize concomitant pathology, malalignment, the graft choice, and finally the graft size. So we will look into each of these issues in detail. So we all know this picture. We all know what are the landmarks of an ACL, both in the tibia and in the femur. So the most common error is seen in the femoral side, on the technical error, and mostly it is put on an anterior and shallow, or it could be a vertical tunnel when you are doing a transtibial technique. When you are doing a transtibial technique, you always tend to put the graft in a more vertical position. This may cause a negative, this may give you a negative lagman, but the patient will have a continued rotational instability, or a pivot may be positive. So you can see in this picture, you can see on the right top, you can see a vertical graft. It's too vertical. In the MRI and the screws also points towards a vertical graft. So this is a recipe for a failure. So tibia, the most common technical error is putting the graft in a more posterior position, which can impinge on the PCL. Sometimes you can also err towards putting it on more on medial side. So these are the most two important things which you have to look in the tibia when you're putting the tibial tunnel. And see, this is a very important paper. It says that more than 25% buttons are not flipped properly. So I always use this as a CM when I'm in doubts, when I have any doubt about flipping of the button. So it could be either in the tunnel, or partially in the tunnel, or maybe partially in the tunnel and partially outward the tunnel, or it could be impinged between the soft tissues of the femur. So when you are using interference screw, you should be very careful in putting the screws. You visualize your screws when you are putting the screw. Avoid divergence. Divergence more than 15 degrees is a recipe for a failure. Watch out for blowout, posterior blowout. If there is a posterior blowout, that's not the end of the story. You can always use a suspensory fixation. You can take out your screw, or you can go for. You can take out your screw, and you can always go for a suspensory fixation. So unrecognized associated lesions. These are associated with the repeat ACL failure. So whenever you see an ACL with a high-grade pivot, look into these lesions like a multi-ligament injury, a posteromedial or a posterolateral corner injuries, a meniscal root tear, ram lesions. Look for the increased tibial slope and an ALL injury. So meniscal tears. So the multiple studies show increased rotator laxity when present with the ACL and a meniscal tear, and it's also shown that there is an improvement with the repair of the meniscus along with the ACL. The rotational laxity get improved with the combined ACL and a meniscal repair. Lateral meniscal root tears and ALL play a role, very important role in anterolateral laxity. The lateral meniscus root is more important in extension, and the ALL is more important in flexion. So ram lesions increase rotator laxity at 30 and 90 degrees even after ACL reconstruction if it is not repaired. So MRI may miss a ram lesion. So if there's a doubt, we put a posteromedial portal and probe the posteromedial meniscus. Look for any dissociation with any capsular dissociation with the capsule. So the tibial slope. So this is a biomechanical studies have shown there's a linear increase in ACL graft force with increasing tibial slope. Sorry for the mistake in the typing. It's not tibial force, it's the tibial slope. Consider slope reducing osteotomy when the slope is more than 12 degrees. in revision cases. But you should know that the tibial slope correction is not a simple surgery. It should be trained, and it is associated with a lot of complications. But whenever you are doing a revision, and if you see a slope more than 12 degrees, consider doing an anterior crossing or osteotomy to correct your posterior tibial slope. So the another thing is adding a lateral extra-articular tenodesis. So when you consider LET, when there is an ACL reconstruction with high-grade pivots, in case of revisions, younger patients less than 25, when there's an increased hyperextension more than 10 degrees, and the Brighton score more than 4 degrees, always consider doing an LET. So biomechanical studies showed decreased internal rotation at flexion angles above 25 degrees, decreases the pivot, and of course it decreases the forces on the ACL graft, but it can over-constrain the knee. So always balance between over-constraining of your knee and ACL revision failure. So what are the graft choices? You can use a soft tissue graft, or you can use a bone patella tendon graft, but literature did not show any difference in revision rates between these grafts, whether it's a soft tissue graft or it's a bone patella tendon graft. But the graft size is very important. More than 8 millimeters seems to have a lower failure rates in most of the studies. One failure in every 87 cases of if you are using a 7 millimeter graft, and the lower rupture rates by 0.86 times for every 0.5 millimeter diameter increase. So you make sure that you use a graft which is more than 8 millimeter. So 7 millimeter or less is not acceptable. It is associated with a high rate of failure. So coming from technical failures to biological failure, it could be a stiff knee post-operative, it could be an infection, allograft, irradiated graft, and graft incorporation. All this can cause a biological failure. So arthrophobosis is very rare. It's seen in less than 2%. It is more common in females, and it's just got a high risk when you are doing a combined surgery like a multi-ligament injury, cartilage procedures, or a meniscal repair along with your ACL reconstruction. So what we have thought is that there is an increased incidence of arthrophobosis when you are doing the surgery within the first month of surgery. But the new data suggests early ACL reconstruction is more cost-effective, and it's a preferred surgery from the Moon data. And other studies also showed improved results with the acute ACL reconstruction when you're using a hamstring graft. Even though I have told acute ACL reconstruction, the knee should not be angry. There are some prerequisites. The knee should not be angry, and you should be able to get a full range of motion before embarking for your ACL reconstruction. But you don't need to wait for 1 month or later, because it has shown that it is associated with the cartilage injury and meniscal tears. Infection is very rare. It's ranges from 0.14 to 1.76%. So what I've thought is my thinking was like allograft and BPT are associated with the more infection, but the literature says autograft has got a more infection and the hamstring has got a more infection than a BPT. And there is a definite improvement with the vancomycin soft graft. It's cost effective. The incidence decreases below 0.014%. You compare it to the 0.14%, so it can decrease 1 by 10. It can reduce infection in every 10 cases. It can reduce infection of 9 patients. So coming to the allograft versus autograft, the patient in the age group of 10 to 19 in children, they had a highest percentage of graft failures, and the odds ratio for a graft failure with the allograft reconstruction are 4 times higher than those of autograft reconstruction. So if you are using an allograft in children, they have got a very high, 4 times higher rate of re-rupture, but it evens out after the age of 40. There is not much difference between using an allograft and autograft, but in children, a strict no to using allograft. So coming to the final thing is the patient-rated factors. So in children, why are ACL tears in children are different? It's not only because of the physis, because of, as I already told, retear rates of at least 25% in children under the age of 14. So the retear rates are very high, up to 25% in children. So this is a study. They have compared 3 groups of children. one mean age group of 16, another was a mean age group of 14, and the third one was 12. And they have found a group 2, that's the mean age group of 14, had a significantly higher revision ACL rate than the other group. So why it is so? Because the puberty occurs usually in this age group of 13 to 14, and there are a lot of hormonal influences, and the neuromuscular coordination is different. So they are the high risk, risk of ACL tear and re-injury. So we know there are other risk factors, risk factors like a female. Of course, they have got a high Q angle. There is an increased laxity, and definitely female genders are prone for more ACL tear and ACL retear and a bilateral ACL tear. So you look at this picture, it's a female athletes. You can see femoral adduction. You can see a dynamic valgus on the knee, and you can see an ankle eversion. These are on the landing pattern. These landing patterns are a sure recipe for an ACL tear and a retear. So the training is very important. You need to avoid all these like things like a femoral adduction, a dynamic valgus, and ankle eversion. And other thing is that the quads dominant. More than the landing pattern, the quads dominance. So with a you can see in this picture the very strong quadriceps. When there is a quad dominance associated with the hamstring weakness, it's associated. It's also associated with the high ACL tear, asymmetric ligament, and legs force strength is also associated with the repeat ACL tears. So these things like core strength, quads dominance, decreased hamstring strength, the landing pattern, all these things are modifiable. And these things you can, of course, after ACL tear, you should make sure that the patient's landing patterns are getting corrected. So injury prevention is more important. And in summary, you can do the ACL reconstruction early, but make sure that you avoid an angry and inflamed knee. And vancomycin soft graft has got a definite advantages. Definitely prevents infection. No allograft for young patients. And anatomical graft placement, especially in the femoral side, is very, very important. In patients with the high-grade pivots, look for associated injuries. Like a posteromedial or a post-collateral bone injury associated with meniscal injuries, ramifications. And in revision cases, always look for the posterior tibial slope and consider doing a slope correction if your posterior tibial slope is more than 12 degrees. Young patients, hyperlaxity, high Brighton score, high-level athletes, cutting sports, and revisions. Consider doing a lateral extra-articular tenodesis autograft. Thank you for patiently listening.
Dr. Unni is moderating.
Yes,
Dr.
sir,
Unni is here. Yes, please.
Initially, there was a problem with my computer. That was a issue. Yeah. Is there any questions?
Yeah, Dr. Prince, what is the most common cause of failure for ACL reconstruction in your practice, you see?
In my practice, it's re-injury. It's re-injury, retear. Not a technical failure. Because I think most of our colleagues are well trained. I don't think anybody will embark on a ACL surgery without having a proper training and knowledge of the ACL anatomy. So in my practice, more than 50% is retear rates, retear.
And I think most of them are because of poor tunnel placement.
Maybe different in different practice, but what I see is retear because of we are more giving concentration on training rather than fitness. So that's one of the issues because the landing pattern has to be corrected in all athletes. Of course, technical errors are there, but I don't want to point fingers on my colleagues. I think it's more of a re-injury.
It was rightly pointed about the rehabilitation and strengthening. So we usually don't concentrate much on the rehabbing of a patient who is a athlete who has injured his ACL after ACL reconstruction. After knee replacements, we just tell them to lift some weights with the leg, and that's what many of us give the patients after ACL as well. I think more of athletic training and balance training and plyometric training like jumping and balancing should be advised before going back to sport, which is not properly done in our part of the world, I feel. That also could be a reason for the re-injury, as Dr. Prince.
Yeah, sure. Yeah, true, very true. And there are FIFA guidelines. There are very good guidelines for that.
Correct.
Dr. Prince,
Yeah.
I have I mean, in your presentation, in one of the slides, you said one of the studies you showed, where you said more than 25% of the suspensory fixation devices are not flipped properly.
Yeah.
I mean, I mean, which I would like to refer to that particular study, because to me, I think that's quite a huge number.
Yeah. I will send it to you. So I will send the document PDF.
Because 25% of the
Yeah, I was
It's a
also
big
I was
number.
also amazed.
Probably flipping over the IT band or away is also part of it, isn't it?
Yeah.
I'd say most of these cases are with the adjustable loop. If you see,
Adjustable loop.
most of these flipping issues are with adjustable loop rather than fixed loop. Because fixed loop by anyhow it gets there. But adjustable, sometimes what happens, if your assistant sometimes pulls the wrong thread, it lengthens the length, or sometimes if it is not flipped properly, you get flipping in the soft tissue, or sometimes it's get flipped and locked inside the tunnel also. So I think it's
Right.
always a good practice to see in CR, as Dr. Prince told.
Can I add to that? Hello?
Yes, sir. Babu, sir, please.
Yeah, about the flipping part, you all put the scope in the anterolateral portal only when for the adjustable loop, not for the fixed loop. Have you tried putting the scope when the button is going through the femoral canal? If you switch the scope to the anteromedial portal, you can actually, and turn the light cable, you can actually see the whole button going, and then you can see it going out of the tunnel.
Yeah, true, very true.
Yeah, and then that flipping is almost complete. So of course, CM you can always use, but then I've used this technique, and it's very, very useful, because when we put the scope into the anterolateral portal, and then you never know. Sometimes you get the toggle, sometimes you don't get the toggle. So this has been a very good technique for me. I mean, I've been doing it for the last.
Schiller,
Testing is when you.
Schiller, sir, this is a study. This is a study which is on top of the screen. You can see.
Yeah. Thank you very much. Yeah, but I have my doubts regarding the 25% not flipping. Means it's quite a huge number. I mean, that means you should. Essentially, what the study is saying is that you should stop using this technique. Because one out of 4 patients are going to fail.
No, it's not flipped properly. It's not that it's going to fail. It says it's not flipped properly.
Yeah, I mean,
is this a very old study? Which year is this?
I think it's 2003. I mean, after 2000.
Yeah, I mean, it's quite an old study. Yeah, maybe that's the time when these devices.
Probably in the learning curve.
The adjustable loops actually started coming into the market. 2003. Yeah. But I still use only the closed loop. I don't use adjustable loops.
Same here.
Prince sir, what are the biological factors that can cause this graft failure? Is there any study or?
Yeah, as I've told, that the reason could be an infection. It could be using allograft in children. It could be a stiffness, or it could be any problem with the graft incorporation. These are the reasons causing a biological failure. But that's less than 10%.
Right.
But in children, it's there's a 4 times increased rate of re-rupture if you are using an allograft. Infection is another reason, but infection is very less. It's less than 0.14%. If you are using a vancomycin soak graft, it again reduces by 0.014%.
Is obesity a risk factor for retire?
I haven't seen any literature. Maybe I should look into that.
Okay. Is there any questions left?
Okay, Dr. Prince, what autograft are you using routinely?
I am using a hamstring autograft, all for my primary cases. And for all revision cases, I always use a BTP graft. Whenever possible, I always use a BTP graft. And regarding obesity, I have read one article, and that says there is not much increase in obese people, and one reason may be they are not embarking on a high-level athletic activity. That may be one reason. They have not found much difference between obesity and obese people and other people. One reason maybe they are the obese people are not going for high cutting and high level athletic activity. That may be one reason. That is
Right.
one study I have seen.
What about double fixation of graft? Is there any
On the tibial side?
on the tibial side and also femoral side? Also, some
Femoral
people are
side.
doing an aperture and suspensory.
I have not seen anyone doing double level fixation on the femur, but I always do. I always do on the tibial side whenever I'm in doubts.
Right.
And sometimes it's ligaments in audio.
Yes.
Dr. Prince, Dr. Joy here. I just wanted to ask regarding the adjustable loop.
Yeah.
So, is there any advice for most different companies or different mechanism of locking locking the adjustable loop system? So, any advice for the people who use adjustable loop, like to put a note there, or is there any use for that, or do we just need to follow the what company says? No need to put any notes and all. So, what is your
Yeah,
advice?
the advisable loops on biomechanical studies, they have shown there's a slight increase post-operatively up to 1 millimeter. But I think they have stood the test of time. Millions and millions of people have used adjustable loop without much difference. So I think the best thing definitely is use a fixed loop. But it has got, you should be thorough with the technique. But I think for the beginners, you can use adjustable loop and you can use nodes. You can always put a note.
Prince
So,
Jyoti Prashant here. Can I have a question?
Yeah.
Prince which bioabsorbable material you used in bioscrew? Because do you have any history of any reaction to it or any bioscrew induced tibial tunnel problems which you need to revise?
I never revised, but the literature shows there's some increase in peak. I think so, but I have never had an issue with the this one, the bioscrews. Maybe I may not be doing that many number of cases, but I think we have to look into the literature.
We do get granulomatous reaction to the bioscrews. We get at least 1 or 2 cases every year. And not to the peak, of course. Peak is inert, it's a plastic. Like especially the tricalcium phosphate and all the other biocomposite screws which you have nowadays. It's got nothing to do with the quality of the screw, but some patients definitely their biology reacts to these screws, and it is usually a sterile reaction, and they develop a small kind of a swelling at several months after the procedure. I mean, no inflammatory markers, nothing is going to be positive. But if it doesn't subside and if it continues, what you actually, if you try to explore, what you find is a white toothpaste, a chalky kind of material, which is coming out of the tunnel. So if you can carefully curate that out and wash it, usually it settles down. We never had these problems with the titanium screws because titanium screws are always safer. But
yeah,
because patients need these bioscrews, they ask for it, and of course you don't because you have to use them nowadays. But you do get reactions to these bioscrews. Even the most modern biocomposite ones. Once in a while we get at least 1 case in a year, 1 or 2 cases. I don't think it's like a huge number.
Yeah, once I did a meniscal repair on one patient. That's a MBBS student, 3rd year MBBS student, and I repaired the Fast-Fix 360. I put 3-4 stitches, and after 1 month, he came with a swollen knee. I aspirated it. It was sterile. I did a washout. Nothing. I didn't see anything peculiar on the meniscus. But again, after 1 month, again he developed effusion and pain. Again, I aspirated, sent for all cultures and tests, and all markers were negative. And finally, I was brave enough to give a steroid injection, and everything settled with the steroid injection.
Just to add, Prince, I have also had a similar couple of cases like that, and I gave them a short course steroid oral.
Okay.
After the washout, of course, I don't know which but thankfully it settled. So
Ah.
even and this biopsy came with granulomatous reaction, and even the synovial aspiration didn't grow anything twice.
Yeah.
Even oral steroid.
Most of them are low-grade infection actually. And sometimes it's like aseptic synovitis also.
Yeah, the good thing was that the patient was an MBBS student and his father was a doctor working in Bahrain. So he came with the literature. He showed a case report of non-sterile the reaction to fiber wire. So he told, he asked me whether we can try a steroid. Then I told, yeah, of course we can try a steroid. And just because he was a doctor, he was also convinced. I gave a steroid and everything.
Sir, there is a question by Dr. Imran Akhtar from Uttar Pradesh. UP has joined. When you would like to augment tibial site fixation in ACL after putting interface screw? By what method?
When we are
He's
going
from
to
Bharat.
So, sorry, can you repeat that question, please?
It's
Yeah,
there in
sir,
chat
I'll
box.
repeat. When would you like to augment tibial site fixation in ACL reconstruction after putting the interference screw, and by what method?
Sir, are you going to answer?
Yeah, let me just, can I make a comment on that?
Yes, sir, sure.
See, my impression is that when you do an ACL reconstruction, and if you're using a screw, a suspensory fixation on the femoral end and a screw on the tibial end, the weakest link in the entire structure of your ACL reconstruction is the tibial interference screw. There is no doubt about that. Because whenever I do ACL reconstruction, for me, the most nervous part is putting the tibial screw, not the femoral end fixation. The reason being, as you all know, the proximal tibia metaphysis of the tibia is a spongy bone. And you are trying to fix a soft graft onto the spongy bone using a screw. So if you actually come to think about it, there are a lot of variables there. In the sense, the quality of the bone, the size of your tunnel, the tunnel graft match or mismatch or whatever. Because I'm sure most of us use 0.5 increments in reaming. Previously, when we started doing ACL several decades ago, it was like 9, 10, 11. But now you have 0.5 increments. So even if that 0.5 mm, there can be an error, because you can have a 9 mm graft, a 9.1 mm graft in a 9.5 mm tunnel. So there you have a 4 mm space. And then the quality of the bone and so at the end, when you're putting the tibial screw, the entire thing, your fixation, the rigidity or stiffness of your fixation depends upon how much torque you have to apply while you're inserting the tibial screw. And this is purely by your feel. It's a subjective thing. It's something very subjective. So unless you have a specially designed torque screwdriver, which will tell you, okay, you have sufficient torque and your tibial screw is going to hold your graft well. So what happens is, if you think that your tibial fixation with the interference screw is not tight enough, it's your subjective feeling. You can't measure it unless you have a torque screwdriver. So if you think it is not good enough, then you have to, I would advise you to go for a secondary fixation, which you can do by any method. Like it could be transosseous or tying down on a post or putting a staple if your graft is like slightly longer than that. So my take on the secondary fixation is that, but you don't have to always go in for secondary fixation. Suppose your graft, when you're passing, is very tight in the tibial tunnel, just one screw alone would be enough. Where you think like you put a screw with a screw is sufficiently tight.
Dr. Unni, can we go ahead with the next talk and have? There are multiple questions in the
multiple
chat box.
questions, especially regarding primary ACL. That's
so shall we discuss all that at the end after the 3 talks? Otherwise, it might go on forever. isn't
Right.
it? A lot of things to be discussed, a lot of confusions,
Okay,
and
sir.
we are able to hear from the big minds like Dr. Schiller Jos,
Okay.
who has the maximum experience
Okay.
in our part of the world.
Next talk is by Dr. Sujith Mathew Issac. He's a senior consultant at Muttuchara Hospital. I welcome Dr. Sujith Mathew Issac for his talk on imaging study of failed ACL.
Thank you.
Over to you.
Can you see my screen?
Yes,
Yes.
Sujit.
So we'll be talking on imaging modalities of failed ACL. As Dr. Prince has elaborately explained regarding the evaluation of a failed ACL, which includes establishing the cause of failure, clinical examination. Of course, infection has to be ruled out when it is suspected. And finally, coming to the imaging, which includes X-rays, MRI, and imaging in failed ACL includes a primary X-ray, which includes a weight-bearing anteroposterior X-ray and lateral views. In the lateral views, take care to be sure that the posterior femoral condyles are superimposed, preferably in the monomedial stance with at least 15 centimeters of the proximal tibia visible. And the points to be noted on an X-ray include limb length alignment, the tibial slope, hyperextension, tunnel placement, tunnel widening, osteoarthritic changes in the tibiofemoral and the patellofemoral joints, any retained hardware and deposition, patellar height and alignment, and stress radiographs, which include the anterior tibial translation and also the.
Sujit, I think you need to be a little louder. Can you adjust your microphone a little closer to you? Yeah, there's something wrong with your slides. It's going back to the first slide again and again.
Is it showing imaging in failed ACL X-rays?
Yeah, now X-rays. Now it's come. Yeah, now we can see. Yeah.
Okay. So I'll just go back to the X-rays once again. So the points to be noted again include limb length alignment, tibial slope, hyperextension, tunnel placement, tunnel widening, osteoarthritic changes, retained hardware, patellar height and alignment, and the stress radiographs. We'll look at these.
Yeah, now we have got it.
Has it changed to limb length alignment now? I'm sorry, I don't know.
Yeah.
Yeah. We have
Previous
the limb
slide we
length.
couldn't see actually.
Okay. Now we are on limb length alignment, right?
Yes.
Yes.
Thank you. This has to be measured on the long weight-bearing X-rays, APB, of course. And we measure the mechanical tibiofemoral angle, the mechanical axis of the femur from the center of the femoral head to the center of the knee, and from the center of the knee to the center of the ankle to assess how much is the deformity, whether it's a varus or valgus. And of course, we also can measure the MPTA and the LDFA, that's a medial proximal tibial angle, and the lateral distal femur angles to know where exactly the deformity, so as to plan the osteotomy if it's indicated. A varus or valgus deformity of more than 5 degrees is
Dr. Sujit, we are still not seeing your slide.
Yeah, now we can see. Yes.
okay.
Go ahead. Yeah.
Okay. So, in a varus or valgus deformity of more than 5 degrees, osteotomy is indicated when it's associated with early osteoarthritic changes or cartilage damage, when there's a symptomatic meniscal deficiency or any other ligamentous deficiencies. So, coming to posterior tibial slope, this is measured on the lateral knee X-ray. We measure to the midpoints of between the anterior and the posterior tibial cortices at 5 and 10 centimeters from the distal to the tibial joint surface. And this line is drawn proximally, and the perpendicular to this is drawn. And the yellow line you see there is the line tangent to the anterior and posterior edges of the medial tibial plateau. And the angle between these two measures the posterior tibial slope. The normal value being 9 plus or minus 3 degrees. An angle more than 12 degrees is critical. And a slope reducing osteotomy or an extension osteotomy should be considered in patients with a posterior tibial slope of more than 12 degrees. The indication is stronger in patients with an increased static anterior tibial translation of more than 5 mm on a monomedial stance, multiple failed ACL reconstructions, and a deficiency of the posterior medial meniscal horn. And of course, make sure that the patient doesn't have a hyperextension of the knee, which may be a contraindication for an extension osteotomy. Which brings us to the hyperextension. Hyperextension should be always looked for, and more than 5 degrees can stress the graft, especially in the which can cause amputation of the primary graft especially if especially if the graft is fixed in tension in 20 degrees of flexion, which we all do. So take care to know whether the patient has a hyperextension. Is the slide moving now?
Yes, yes.
Thank you. So coming to tunnel placement, as Prince said in his talk, femoral tunnel misplacement ranks very high in the cause of along with in the cause of technical failures of an ACL, primary ACL. And that's probably one reason, maybe because there is no universally accepted definition for the proper anatomical femoral tunnel placement. And one thing which will help to just look at where the position is would be the Hartel's grid, which is drawn by first measuring the tangent along the Blumensaat's line, and then a line parallel to the Blumensaat's line, cutting the inferiormost border, the distalmost border of the lateral femoral condyle. And then two perpendicular lines are drawn through the anterior and posterior borders of the lateral femoral condyle. This has to be in a true lateral view with both the condyles superimposed. And to find the lateral femoral condyle, the lateral femoral condyle will have a small notch on the distal part called the Grant's notch, and the medial femoral condyle will be extending distal to the lateral femoral condyle. So that is how you identify the lateral femoral condyle. And once the grid is drawn, the grid is measured from posterior to anterior and the posterior superior to inferior. And the center of the ACL femoral attachment is supposed to be 28% along the Blumensaat's line from posterior to anterior. Sorry, it's mentioned 26 degrees in the picture, and 34% superior to inferior along the height of the intercondylar notch. So that is what is accepted in most of the studies. This is some of the studies which is measured the femoral ACL attachment. And a misplaced femoral tunnel may be considered when the center is outside this area. And the area is, this is from the AASK guidelines recently published in 2022. And according to them, the normal center of the femoral footprint should be within 19 to 29% along the Blumensaat's line from posterior to anterior, and within 22 to 53 degrees, a percent from superior to inferior along the height of the intercondylar notch. So anything outside this is considered to be a misplaced femoral tunnel. So the measurements are with 19 to 29% from posterior to anterior along the Blumensaat's line, and from superior to inferior between 22 to 53%. If the center of the of your tunnel is within this limits, it's considered to be a normally placed tunnel. Anything outside is a misplaced femoral tunnel. Coming to tibial tunnel misplacement, this is measured on the lateral view, and here we draw a Ames-Jacob line, which is a line which passes through the posterior corner of the widest part of the medial tibial plateau. That is a square-shaped margin of the posterior part of the medial tibial plateau, and it is that red line. It is drawn parallel to the joint surface, and the average position of the center of the ACL tibial attachment is supposed to be 40% from anterior. So a misplaced tibial tunnel may be considered when it's outside the range of 30 to 50%. So anything within 30 to 50% from anterior to posterior is considered to be a normally placed tibial tunnel. These are again some of the studies. These are some examples where here in the slide, both the femoral and the tibial tunnels are totally misplaced, where the femoral tunnel is vertical and the tibial tunnel is posterior. When the tunnels are totally misplaced, probably the revision is a little more easier because the new tunnels might not coalesce with this. And here, the tunnels are normally placed and not much widened. Again, this also makes the revision easier. When the tunnels are partially correct, that is when the problems arise, because the new tunnels might coalesce together and results in a really wide tunnel, and which can cause problems. Which brings us to tunnel widening. Tunnel widening can be assessed on the X-rays, but if there is any doubt regarding tunnel widening, it's always better to do a CT. And we'll discuss tunnel widening along with CT scan. Coming to osteoarthritic changes, a flexed knee Postero-anterior weight-bearing X-rays of the Rosenberg views have higher sensitivity to document joint space narrowing. And the KL scoring for the osteoarthritis is assessed on the AP extension weight-bearing X-rays, where it's graded into 0, 1, 2, 3, and 4. And the skyline views are also seen to assess the patellofemoral overlay and alignment. Coming to CT scan, here again the tunnel position is verified again, and tunnel widening is also assessed. Tunnel widening is most reliably assessed by the CT scan, and is measured on the axial, coronal, and the sagittal slices. Here, side-to-side measurements are done through the widest part of the tunnel widening of more than 12 to 14 mm. Again, there is no clear-cut single value, but different studies mention 12 to 14 mm as a critical value, beyond which may be a relative indication for bone grafting or a two-stage procedure. The details of this will be talked about by the next speaker. Coming to MRI, MRI has limited sensitivity and specificity for the diagnosis of an ACL graft, but it is of course required to assess additional pathologies like the meniscal status, other ligaments like PCL, MCL, LCL, the extensor apparatus, cartilage and subchondral status, bone bruises, and the hardware. So to recap, points to bear in mind from the imaging workup of failed ACL includes measurement of the limb length alignment and a varus or valgus deformity of more than 5 degrees should be a consideration for additional procedures. Posterior tibial slope of more than 12 degrees along with associated conditions may be an indication for an osteotomy. Hyperextension of more than 5 degrees should be carefully considered, and maybe a two-stage procedure may be considered in such a scenario. Thank you for the patience.
Thank you, Dr. Sujit, for the excellent talk. Is there any questions regarding imaging?
Sujit, for me, the critical value is 16 millimeter, because anything more than 60 millimeter, you need a two-stage procedure. You need the bone grafting and a second ACL revision at a second stage. But up to 60 millimeter, you can manage. If you have an allograft, you can manage with a BTB allograft or a tendoachilles allograft.
Yeah. I mean, because if it's especially also it depends on how much it's widened. Like if it is a circular one, the BTB graft will be hexagonal or rectangular. So that can probably fit in a slightly wider tunnel as well. So even if it's 16 or even 18, you can get away with it. But it's also on the shape of the tunnel widening.
Okay.
Dr. Sujit, I have one question. Sometimes the MRI report may come as sprain or interstitial tear or partial tear. The patient will have a significant instability. So how will you address that condition?
See, that's what I said. Most of the studies say the sensitivity and specificity for diagnosing from the MRI itself is because there will be a lot of fluid inside in between the graft. So the anatomical, it might be continuous, but how is functional status of the fibers may be difficult. So a thorough clinical examination has to go with that. One cannot really say from the MRI itself, because it has low sensitivity and specificity, whether it has retorn. So stress test, clinical examination is a must to arrive at a diagnosis, and also symptoms, whether he has instability symptoms, the pivot shift test, all that has to be taken into consideration.
So it's a clinical diagnosis that is more important than a radiological one, right?
Can we do the next talk also and then take all the questions together?
Already, yeah, that yes.
Okay, sir. Okay.
Okay. Fine.
So next talk is by our invited faculty, Dr. Rajeev Raman. Is a very famous person from West Bengal. He will be dealing with the techniques of for revision ACL surgery. Over to you, sir.
Yes. Thank you for this opportunity, and thank you, Sujit Boss. So I will be talking about revision ACL reconstruction. And if you see the indication for revision ACL reconstruction, patient with a symptomatic unstable knee that interferes with desired patient activity level. This is very important, as we were discussing in just before. So who are the ideal patient? It's important that patient should be clinically unstable and not the MRI which shows partial or near complete ACL tear. This is very important. Sometimes this patient with a near normal ACL reconstruction with almost more than 50% attenuation of the tendon has no symptoms of instability. So those are not the ideal candidate for revision ACL reconstruction. So symptomatic unstable knee is the important criteria when you plan for revision ACL reconstruction. And if you see the causes as we have discussed, it's like most common cause, as Dr. Prince told, it's traumatic re-injury. Second most common is your technical fault in the femoral or tibial tunnel. And third most common cause is your biological failure, when your graft diameter is very less, or sometimes your graft is quality is not very good. These are the common causes of ACL. To determine the cause of primary failure, I think it's very important. Failure don't plan to fail, they fail to plan. And this is very important. So first and most important part is radiological evaluations. Assess X-ray, see the hardware, tunnel placement, and
Excuse me, sir.
Audio is not going. Audio is not coming.
expansion. So these are the, whenever you are length upright hip, audio is not coming.
Audio now it's coming.
Now I'm audible.
Yeah.
All right. Yeah. So see for the hardware, what implant you have used, whether it's a bio screw, it's a endo button loop, or it's a disc there, whether it's a multiple implant, it was a multiple ligament injury. See for the tunnel placement. Sometimes you will see that your tunnel position in malposition, and see for tunnel expansion also. That will give you an idea of whether you will go for a one-stage ACL reconstruction or two-stage ACL reconstruction. So radiographic evaluation, the second part is either MRI or CT. So for revision ACL, I prefer both the MRI, magnetic resonance imaging, and the computerized tomography also. So MRI will give you some important clause of meniscus and cartilage injury and multiplanar ligament evaluation. So what is your condition of your primary graft? And the most important part of the CT is that it determination of tunnel osteolysis. And most of the time we see the ballooning of the tunnel, which is there. And hardware usually is not an issue with CT, because what happens sometimes with MRI, if you have a titanium implant, or sometimes you will see a lot of artifact around the implant. So when you do a CT, usually you will see these artifacts are not there. So measurement of the tunnel diameter is best with the CT scan. So influence of limb alignment. This is very important whenever you are planning for a revision ACL reconstruction. So normally, if we get most of the patient with a varus malalignment, and what happened, because with varus malalignment, the ACL deficiency is exacerbated, and most of these patient has medial compartment osteoarthritis, and sometimes you will see this varus malalignment has associated posterolateral corner insufficiency. With the alignment, also see for the posterolateral corner insufficiency. And in some situation with the new design plate, you can plan for a combined HTO and ACL reconstruction. So what is important? See for the anterior laxity and medial compartment osteoarthritis. And if you plan for an HTO with ACL reconstruction, most of this, yeah, am I audible?
Yes, sir.
Yeah.
So HTO with ACL reconstruction, usually it decreases the strain on the revision graft and decreases the strain on the posterolateral corner also. So these are the two advantages of when you are planning for a HTO with the ACL reconstruction. The $1 million question is single stage procedure or you plan it in a two-stage procedure. So most of the cases you will see, you can plan it in single stage procedure. And what are the indication for single stage procedure? Properly positioned tunnel with good bone stock following hardware removal. So whenever you have done your measurement of your tunnel dilatation also, so once you put your scope inside, see whether your tunnel position is good. You have evaluated your tunnel radiologically, and after removal of the hardware, see what is the condition of your tunnel. And then if it is properly positioned, it's not wide, and you can plan for a single stage procedure. And sometimes when it's a poorly positioned tunnel, such that primary tunnels and hardware do not interfere with the proposed position of the new tunnel, you are dealing with a revision ACL where ACL reconstruction was done transtibial. So you have a vertical graft, and you can put your new graft in the anatomical position. So sometimes the transtibial ACL reconstruction, which comes to you as a player, it's a blessing in disguise for you because you have a virgin bone there. You put your anatomical ACL reconstruction. So what are the indications for two-stage procedure? Most important part, as we discussed in our previous talk also, tunnel widening. So most common indication for two-stage revision ACL is tunnel widening. Again, as it was discussed, if it is literature varies between 12 to 14, more than 14, Dr. Srimas told more than 16. So more than 10 to 15 millimeter of widening, usually you can think about two-stage procedure. So stage one, you plan for a bone grafting. You can take a iliac crest bone graft, put inside the tunnel. And stage two, you can plan for a revision ACL sometime after seeing the CT scan after 3 to 6 months that yet yes, graft has already incorporated. You can plan revision ACL reconstruction in this bone grafted tunnel. So another indication for two-stage procedure are more than 5 degree of extension lock and more than 20 degree of flexion loss. So never plan for primary ACL reconstruction if your revision ACL reconstruction if your patient is having more than 5 degree of extension and more than 20 degree of flexion loss. So try to rehab this patient, rehab them properly, and then plan for your revision ACL reconstruction. So what are the technical considerations? The most important part is anterior femoral tunnel. So what happens? It is one of the most cause of failure, and most of these attenuation or rupture occurs because of regular attenuation of the gut at the roof of the tunnel. So what is the solution? Try to make UCC. If it is a far anterior, you can make separate tunnel. If it is a blended tunnel, redeal with two incision technique and non-aperture fixation. And if it is, you can see it's a widened tunnel, you can plan it for a two-stage revision with a bone graft. So vertical femoral tunnel. This is the second common scenario we get in our practice. So nowadays also, you see lot of arthroscopy surgeons still prefer transtibial technique, and most of the tunnels you see the vertical. So the problem is sagittal stability with rotational laxity, usually due to vertical tibial tunnel. So what to avoid? Build femur from anteroposteal portal, beware of the MFC and posterior boulevard, and hyperflex knee to 105 degree, and again two incision technique. So what are the management? Redrill appropriate tunnel and use suspensory fixation. So most of this tunnel you can use, and for revision scenario, my fixation device for the femoral side is suspensory fixation always. So tibial tunnel issue. Tibial tunnel issue, if you see, either your graft is too anterior, so that causes the impingement of the graft, and most of the patient comes to your clinic with loss of extension. Sometimes the graft is too medial, so damage to the medial tibial plateau. Again, this patient comes to you with loss of extension. And sometimes what happens, if you are doing a multi-ligament injury, ACL with PCL, you try to put your graft too posterior, and you see that the vertical graft, and there is a loss of extension and no rotational control. So these are the three issues with the tibial tunnel, and you should address it. So tibial tunnel issue, how to manage? So most important part is redrill tunnel in optimal position. Normally try to have a divergent tunnel. As you can see here, this is my primary tunnel 1. The second tunnel is divergent tunnel. So again, it is at the anatomical location, but a new bone, with a new bone. So you are just putting it divergent 15 to 20 degree away from your primary tunnel, and fix this suture over post or disc. So I usually don't prefer pushing a screw in a revision scenario and tibial side also. Most of these revision cases, either you use a suture disc or a post. And if your tunnel diameter is more than 20 millimeter, so again, for the tibial tunnel, you have to plan for a stage procedure, go and graft your tunnel, and go for a stage reconstruction after 4 to 6 months. So stage bone grafting, again, what are the indication? Tunnel expansion of more than 15 millimeter. So what happens most of this time, it's very important because rigid fixation is difficult, and it precludes acute graft placement and prevents native bone incorporation. And the technique is, most of the time, remove all the fibrous tissue, visualize the tunnel, cancellous or autograft from the iliac crest, or sometimes you can use the allograft also, and try to do CT scan after 6 months. You see, as in this case, you can see the incorporation of the graft. Then you can plan for your revision ACL reconstruction. So let's summarize. So most important part is determine the cause of primary ACL reconstruction failure, and that is key to successful revision. So if you have malalignment, address the malalignment with revision ACL. If you have a tunnel malposition, address the tunnel repositioning in when you are planning for a revision ACL. Determine the patient symptoms. This is very important. Knee instability should be the primary indication for revision reconstruction. It's not the MRI finding which suggests partial or near complete or total ACL reconstruction. It's the instability of the knee. The patient will complain, comes to your clinic, yes, I am having a giving way in spite of having ACL reconstruction 9 months before or 1 year before. So this should be your primary indication for revision ACL reconstruction. And always determine all relevant comorbidities. That is important. A careful physical examination, review of relevant imaging studies is a very important tool in planning of your revision ACL reconstruction. Determine patient goal for surgical outcome, because not all failed reconstruction required revision. Anatomical graft placement must be a priority. Most of the time, you try to put your graft in near anatomical position. Sometimes very difficult. Sometimes you have to revise your tunnel, but try to put it in anatomical position. And always address all comorbidities. A stage procedure is indicated if the morbidity of the combined reconstruction outweighs the chance for a safe surgery. And set realistic expectation pre-operatively. Always discuss with your patients, this is the cause of the failure, and I am planning it in 1 stage or 2 stage, and why I am planning your revision ACL reconstruction with the HTO, why I am planning your revision ACL reconstruction with the bone grafting as a primary procedure. Thank you.
Thank you, Dr. Rajeev Raman. Is there any questions?
What graft do you put for revision?
Yes, sir.
Can you hear me?
I think your question is what graft?
Yeah.
Yes, sir. So most of the time, sir, I use iliac crest bone graft, and with the probe you measure the, or with the reamer you measure the tunnel diameter and try to take 0.5 millimeter more graft, and so that it's stuckly fixed inside your femoral tunnel or tibial tunnel.
You use GTB or semi-T?
Oh, for revision ACL reconstruction graft. Oh, I was thinking about bone graft you were asking. So my preferred graft is bone patella tendon bone graft, because it acts as a filler, and second, your healing is also faster because it's bone to bone healing.
Dr. Rajeev Raman, thanks for that wonderful presentation. You mentioned in your presentation that you always prefer suspensory fixation on the femoral side for revisions. Am I right?
Yes, sir.
So if you're using a patellar tendon for patellar tendon bone for revision, you use that special endo button designed for patellar tendon, or do you put a screw on the femoral side?
So it's a double fixation for me, sir. I use a suspensory fixation with a screw inside the femoral tunnel as a filler.
That question is very pertinent because fixation might be a problem if the tunnels are nearby. So we have to rely more on suspensory. Yes.
Yes, sir.
We have very good questions in the chat box. Dr. Unni, could you please look at them?
Yes, yes.
Okay, one question is by Dr. Vyas, how to proceed if femoral side posterior blowout occurs? That's a question regarding
I have answered the comment box. I have already answered the comment box.
Yes, sir.
Okay.
So I think suspensory fixation is your choice. Answer. You can't use a aperture fixation if you are planning also.
Okay. The next question is many times after the final fixation with screw on tibial side graft, the tibial side graft may look like a little loose. What to do for it?
Put a post.
Yeah, do additional fixation.
No, you can't just add a post. If you think your graft is loose, you have to back off your screw, tighten your graft again, put a larger screw, and then add a post.
Yeah. And the other option is that if you are using adjustable loop on the femoral side, you can tighten a little bit more.
Tighten it.
Yeah.
Yeah. The next question is, what are the indications or advantages of all inside ACL reconstruction? It's also regarding primary ACL.
If your graft size is the length is less, I think it holds some promise. I think that's the only advantage.
Are you guys doing all inside or not doing? What's the consensus on all inside?
Yes.
I
I
use
am
for
not doing.
skeletally immature. Yeah, only for
Yeah,
skeletally immature patients.
sculpting mature. Yes, yes, yes. That is the ideal indication.
So the next question by Dr. Vyas is how to decide tibial side interference screw, +1 or +2 size. That's also primary ACL.
So
How
I
to
put my trocar in between the graft and the tunnel. If it is very difficult to introduce your trocar, it's the same size. If it is going a bit of difficulty 1+, but if it's very loose in osteoporotic, then 2+. So it's like with the trocar, I decide. I put in between the graft and the tunnel, and sometimes in very hard bone, you have to use same side screw also. It depends upon the, uh, I think, quality of the bone.
all right.
It depends on two things, whether you are using a BTP graft or using a soft tissue graft. That's also has to be taken into consideration.
If the patient is more than 40 years, I think 1+ is a good choice.
Yes, yes.
It's
Sometimes in
difficult to have a,
osteoporotic, very bone, you have to use 2+ also.
it's very difficult to have a fixed formula for +1, +2 size screws.
Yes, yes.
Because like I said, it entirely depends upon the how tight your graft is in the tunnel and the quality of the bone.
Yes.
Sometimes I have even ended up putting a smaller size screw because my graft is so tight in the tunnel.
Especially in femoral side, sir, when you are planning for screw fixation, sometimes you have to downsize your screw most of the time.
Yeah, the next question is in anterior impingement, if the anterior impingement is the issue, what is the role of partial debulking or debridement of the ACL graft and the timing of the procedure?
If there's impingement, that means your femoral tunnel or a tibial tunnel is not in the correct position. That's it.
I would. It's better rather than debulking a graft. There's no harm in doing a liberal notchplasty on the roof to prevent your impingement. Why do you want to damage your graft?
How do you actually debulk it? I don't know how you.
I also don't know how to debulk a graft, but I can tell you that the notch is impingement happens when the tunnels are not in the correct position.
Yeah. Debulking means either you have to use a straight punch or a shaver, but that's going to damage the graft.
It's very difficult to debulk properly.
But I think the question he would have thought about a notchplasty.
I think yes.
What Prince said is the femoral tunnel placement is not good. It's definitely going to impinge.
Yes.
Rather than the tibial placement. Tibial placement is tunnel, even if slightly more medial, it's okay because that is actually the stretching of the graft is slightly more, and it's not going to impinge. But the femoral tunnel, if it's too anterior, it's definitely going to impinge. And also, when you after the fixation of both femoral and tibial side, you can also extend the knee and see if it is impinging the notch. That is also one way of confirming whether there is impingement or not.
Yeah, that's what maybe he's asking. It's the timing of the procedure. So after fixation, you look for the notching and then you can debride or not. That's what maybe he's asking.
Debridement, I think it's not very safe procedure to do.
I think one other thing which should be discussed here is anterior cyclops of the stump, which is again preventing an anterior more extension of the knee, causing an anterior
extension lag.
So too much of stump also anteriorly can create this trouble, or an anteriorly placed tibial tunnel commonly.
And also one problem with the notchplasty is in literature, the bone can reform and can produce a spur and can cause a return of the that is described. That is a problem with the notchplasty.
Yeah, in the initial days when we were doing BTB and transtibial, notchplasty was routinely done by many surgeons. Transtibial, because impingement chances are quite high there. But now with the anatomical position, when you put the tunnel from the anterior medial portal, it's highly unlikely that impingement occurs unless the tunnel is too anterior and you have the whole femoral condyle posterior part, lateral middle part of the lateral femoral condyle there. So you can actually choose which area you can. Can you also change the position? You can put a K-wire and see if it is the right position, and then you can change the femoral condyle position before you start drilling with 8 mm or 9 mm.
Most often the problem comes with the tibial part rather than the femoral part nowadays. The tibial part is an oval shape, so one can get easily misread with the tibial stem. That may be one reason. We can get an anterior graft. So we'll go to the next question. Sir, this is to Dr. Rajeev Raman. Dr. Imran is asking, sir, how to have suspensory fixation with the BPTB graft?
Yeah, it's very technical sometimes, and you have to use a probe also to introduce your graft inside and try to make the tip of the graft bullet shaped so that it's very go inside. And sometimes it's difficult. You have to roll around and fix it with the suspensory fixation. Again, because of the tunnel widening, sometimes merging of the tunnel, it's very safe to use a suspensory fixation. And most of the time when I'm using a BPT graft, I use a suspensory fixation with a aperture fixation, which acts like a filler, HA screw or sometimes a metal screw, which acts like a filler for the tunnel also.
Is there any chance to cut through the suspensory fixation through the bone?
Yes, yes. So sometimes this happens, and whenever you are doing an anatomical ACL reconstruction, this is very common because it's obliquity of the tunnel, which causes friction of the this
Right.
suture material over the tunnel. So be careful, try to guide it properly, and you can put your probe inside, make your graft bullet shaped so that it goes inside and it's stuck inside the tunnel.
Okay, right. And also the main problem comes when the graft passes through the tibial cortex, right?
Yes, yes.
So the next question is, can we augment like fiber tape in revision ACL situation? Is it recommended? And also,
For me, it's only for repair, not for reconstruction. So I don't use fiber tape. I would like to have opinion of other faculty.
I think some people uses this fiber tape when there's high extension more than 5 degrees. It acts as a doorstop. It has a doorstopper effect, but usually that should be loose than the graft. Otherwise, the graft remodeling will be affected. But I think now most of the people prefers to do a LET rather than using a fiber tape.
So the next question is an interesting one. Can we do lateral side entry for tibial tunnel in revision ACL reconstruction?
So divergent tunnel is a standard technique. You can use your divergent tunnel technique because your primary point inside the joint is fixed. It's a very small area. So divergent tunnel will give you a raw bone, and you can use 15 to 20 degree divergent so that you have a new virgin tunnel over that. Over that, the graft healing will be good. Most of this tunnel, if you have a screw, you will see lots of sclerosis is there around. Even if you remove the screw, you will see the sclerosis around, and that prevents graft healing.
I think that the question was like, can we use
from the lateral side?
Yeah, that will result in a kiloton. So that is not
Kiloton. No, actually it is described, but again the problem is the kiloton will be more. It can abrade and fail.
Yeah, the next question is there any role for ALL reconstruction in revision ACL?
Yeah, I think that we have already discussed in my slide. If there's a hyperextension, the Brighton score is more than 4. If pivot is more than 2, they are all indications for doing a younger patients less than 25 years of age. They all are indications for doing a LET or an ALL.
The younger patient explosive pivot, if it is there, you can augment ALL with ACL.
Yeah.
Right. The next question is preservation of femoral and tibial remnant of ACL. What's the advice? Maybe regarding primary.
There is no role for a Raman preservation in a revision ACL.
Revision, yes. So primary ACL, yes. Revision, I think we don't have any role of, because most of the graft you will see it's like non-vascularized graft, attenuated graft. So better to clean everything and plan for your revision ACL reconstruction.
Okay. I think that concludes.
Yes, one last question.
Question is
rehabilitation in revision. What is the rehabilitation protocol in revision ACL?
Dr. Rajeev?
Yes, normal. Actually, most of these patients, I use a normal rehab protocol. Only thing is that if you are sometimes you have a posterior blowout, be slow in rehabilitation. And again, after second week, I try to put them more on hamstring than the quadricep because it's agonist of ACL. And for me, the rehab protocol is almost similar.
Rehab is same for both the primary and revision. The rehab depends on whether there's a meniscal tear associated with and you're doing a meniscal repair. Both same for a primary and revision. There is no difference.
I have a small question here. Like when you all go for a revision and go inside, and if you looking at the tissue, if you have a slightest, just by gross appearance, slightest suspicion that there must have been an infection, what do? You just do you go ahead with bone grafting or just come out?
I think the clinical examination is very important. When there's a failure less than 6 months after index surgery, that means there is some technical error. If the technical error is excluded and there could be an infection, especially if post-op rehabilitation, the patient is not able to achieve full flexion extension, they are highly indicative of infection. But an internal normal prelude, if the re-rupture happens after 1 year, that means it could be a traumatic injury, nothing to do with an infection. So I think less than 6 months and more than 12 months is that is the time limit. If in case of any infection, I think it's better to go for a 2-stage procedure.
Do you all normally take out the if you're going for a revision? Do you ever try to take off the endo button or the suspensory button in the on the femoral end, or just leave it behind?
No need.
You just leave it behind, right?
Yeah.
No need of doing that. I'll leave it out.
Unless it is for a revision when you're doing a staged procedure, when you want all the mineral to come out.
Yeah, Prince sir, there is a clarification. The last question was about preservation of femoral and tibial remnant for primary ACL. Is there any relevance? That was
Yes.
Yeah, some people say there's a associated with the good proprioception and everything, but I usually don't preserve the stump in fear of a cyclos formation.
And about
So I think
proprioception, there is
remnant preservation. Yeah, please, Sujit sir, please.
Please go ahead.
I think remnant preservation should not be at cost of poor tunnel placement. So you should preserve remnant, but it should not affect your tunnel placement.
Correct. And there's not more than level 3 evidence about the proprioceptive advantage for a remnant preservation. So you should never compromise your graft and tunnel placement.
Yes.
So another thing I would like to add here is about the low-grade infections and the screw problems, and they are all, I feel, could be partly related to the propionibacterium or the skin commensals, which have been described in various areas, even in Bankert, even with other soft tissue procedures. So soaking in vancomycin has made a difference. That means there is some hidden thing around which can be trouble. So I've changed my practice in the sense I've had a few cases with the screw problems, tibial screw problems. 2 in 2009, they came together, and one was 4 years back. So, so all those 4, I feel there was some hidden thing, and I started adding this gauze soaked in cefuroxime under the tibia on the tibial side on the skin, so that the graft does not touch the skin in any instance. And that has probably changed, and I've never had an infection touch wood till now after that. So that also, I think, can be something which can protect against low-grade infections and trouble like this.
Yeah. That concludes the questions in the chat box.
I think we are all shooting by half an hour.
Yes.
Dr. Unni, do we have any cases to show now?
Yeah, I will show 1 or 2 cases.
Yeah, Dr. Unni had arranged few very good cases. Shall we just, at least one of them we can present now?
Is my screen visible?
Yes.
So this is the 25-year-old male. It's a hotel waiter. Had a surgery, ACL reconstruction 3 years back, and he had a re-trauma, a fall, and now we presented with the instability with a low-grade pivot. So this is a standing X-ray. So any comments on X-rays or and the reconstruction?
Yeah, the tibia appears slightly anteriorly displaced. The tunnel position wise, it's
Yeah,
slightly.
it's a vertical tunnel.
It's not vertical. The button is not seen in the lateral view. It's on the lateral side, isn't it?
Yeah, it's here. The button is here.
Yeah, the entry point cannot be seen. Probably a MRI can tell us, or a CT.
I think the tunnel seems to be a bit vertical. It's very high. If you see the position of the button.
Yeah.
In a 25-year-old,
This zoomed X-ray.
in 25-year-old patient, they have used a accessory tooth fixation on the tibial side.
Right.
The bone should be strong, and you should get away with a screw. That means there is some problem in the tibial tunnel too.
Yes, yes.
Okay. And there
But
is
it
no.
might be just a tibial side post fixation.
Yeah. And if you see the tibial tunnel seems to
I guess with this X-rays, it's very difficult to
Correct.
criticize the ACL reconstruction.
And from the lateral X-ray, you can see that the tibial slope is not that bad.
One thing we can conclude, there is no sital plane malalignment in the standing X-ray. Right?
Yes, yes.
Tibial slope is not that bad.
Yeah, tibial slope is also around normal. Right. So these are the films. Maybe. So this is the diagnosis. So this is the impression. The tibial tunnel is widened, and there is a partial tear of the tibial attachment of the ACL. And there's a partial tear of the PCL also, and there is a meniscal tear, a medial meniscal tear and a lateral meniscal tear. So, where will you go?
You didn't tell about the clinical examination findings. Is it grade 3?
Yeah, grade
Lachman?
3. No.
Grade 3.
Yeah, Lachman is grade 3, and there is a pivot, mild grade pivot.
Okay.
So we'll discuss these points. So this has already been discussed that the decision making will always be clinical. It's not the MRI. So what all investigation normally we'll do in a failed ACL? Is it a X-ray alone, or what about CT in every case? What's the consensus?
I prefer CT and MRI both in revision cases. After
So
doing a alignment view.
In all the cases?
Yes, yes.
Of course, the CT will tell you about the widening of the tunnel, the position of your tunnel, and the MRI will tell you about the meniscus and
Graft. Yes.
graft and other associated injuries like a PLI or a PMI.
Okay, right. So what are the graft options in the revision ACL setting? Normally we use semi-T graft. So what other graft? Is there any preference?
Bone patellar tendon graft is preferred graft. It acts as a tunnel filler and good healing.
Okay, what about quadriceps bone tendon graft?
Yes, you can use the bony part in the femoral tunnel and the soft tissue part in the tibial tunnel. Yes.
Okay. So any role of peroneal tendon?
Peroneus.
Yeah, peroneal, you get a big chunk, big size tendon.
Yeah.
If there is no ligament laxity, Baton score is less than 5. Peroneus also is a good option.
Yes.
Okay, this has already been discussed. Management of a structurally intact ACL with a residual instability.
Yeah.
And the studies have shown that it is the collateral ligament. So, if you overlook the collateral ligament tear, it can the knee can be unstable even though there is an intact ACL. That's the most common thing that can present with. So a posteromedial ligament MCL injury or a posteromedial counter injury or a postlateral counter injury, if you overlook, you can get a residual instability even though there is a structurally intact ACL, even if there is no coronal or sagittal plane malalignment. That's what study says. And regarding single stage, double stage is already discussed. If the tunnel size is more than 13, right? Prince, sir?
15 or 16
14,
or 16.
14 to 16 is the landmark.
Okay, right. And the femoral and tibial tunnel position, how will you identify the femoral and tibial tunnel position? Is there any, since there is no stump, most probably, what about using a C-arm? Some studies describe using a grid technique in a C-arm for revision.
Yeah, it's already been discussed, right? Sujith has already discussed about that.
Okay, right.
Yes.
So a LET in revision ACL. So
I already told about that.
Yes.
Right. Rehabilitation is already discussed.
Normally.
So in this case, we did a straightforward revision ACL using a quadriceps tendon graft. We used to do quadriceps tendon bone graft, and the patient is doing well. This is the second case. Second case is the 21-year-old football player with a high-grade pivot. Any comments on the X-ray?
I think
What's the
tendon
tibial
seems to be-
slope? The tibial slope?
Yeah,
slope.
I think there is an increased tibial slope, which is confirmed by
posterior slope.
Yeah, posterior slope is 14.3. So how will you manage?
How about limb
Any
alignment?
experience for deflection osteotomy? Anybody having any experience?
Have you checked the coronal plane alignment as well?
Yes, there's a increased slope. Tibial slope measures 14.3.
I mean, varus valgus. Is there a varus?
No, there is no standing X-ray available. I think looking at the frontal view, there is a slight varus.
So if there is significant varus, we can do a high tibial osteotomy with slope correction.
Slope correction.
Combined.
So this is the CT.
Adding on to that, if there is a varus alone without a cartilage loss in primary ACL, would anyone do a XTO?
In a young patient, 25 years, I don't. So you need to do that.
I think sometimes if cartilage loss is not there, I think you can come around with only revision ACL reconstruction rather than going for STU.
Correct.
So this is the CT. It clearly shows there is an increased slope and there is no tunnel widening, obvious tunnel widening. And also initial tunnel was also around the anatomical area. So most probably the reason for is the increased slope. So discussion regarding the coronal and sagittal plane malalignment in a revision ACL. So how will you go? How will you go about it? Coronal plane and sagittal plane. So it's
in the sagittal plane, you can do a anterior closing wedge osteotomy,
right,
with staples. But if it's varus, I would do a combined high tibial osteotomy.
Pure with ACL.
With ACL. The newer plates, the Pudu allows, the nuclear plate allows.
Yes.
Combined ACL.
Okay, this has already been discussed. LET in revision ACL, right? So, is there any rehabilitation change if you do a bony procedure along with the revision ACL?
Weight bearing is delayed.
Weight
bearing.
Weight bearing has to be delayed. You can start range of movement exercises.
The thing is that if you are doing an HTO, the weight bearing should be delayed, open medial open wedge osteotomy. But if you are doing an anterior closing wedge osteotomy, since it's a closing wedge osteotomy, you don't need to delay it that much.
Yes.
Okay, sir. That this is okay. Thank you. That concludes the cases.
Those are good cases, Doctor.
Nice cases,
I think that's for the day.
Okay, thank you, speakers, for having a wonderful session.
Yeah, before we conclude, Schiller sir, shall we announce our conference?
Oh yeah, please, yes, do please do that.
Yeah, please. We are planning. I'll just introduce that we are planning a conference probably biannual from now, of ASK in our president's hometown in Calicut. We are professionally, we have had discussions, and we are finalizing on June 1 and 2, Saturday, Sunday, as the conference dates, where we'll be covering most of arthroscopy, sports injuries, cartilage sessions. There will be two halls with lots of workshops, and we are even planning cadavers if possible. So the official flyers and details will be coming through. Dr. Sivin Sudhendran will be the organizing secretary from Calicut, and Dr. Samir Ali, the scientific chairman, and there is all of us have a role there, as Schiller sir has designed the scientific and organizing team. So we'll be coming out with the flyers very soon. Please, please take over, sir.
I mean, I'd just like to add a few words to that. See, if you remember, ASK is going to have its first meeting conducted by ASK itself. Like, we have supported a lot of other meetings, in smaller meetings in different parts of the state. So I would request all of you to participate in both the conduct or planning, as well as the actual execution of this program. So I request all of you to be there, and we value your inputs on like how to go ahead with this meeting, because this is the first meeting ASK is having on its own. So we'd like to do it not too extravagantly, but we'd like to have good scientific session and good discussions, and we don't want to cover all the topics. We'd like to focus on few topics and then go deeper into that. So all your suggestions are welcome. So you can, like, we definitely be continuing with our fireside. I mean, this wisdom trail. So each time we have this wisdom trail till this meeting happens, you can all give your inputs, or even otherwise in a WhatsApp group you can add to, like, if you have any ideas about how to go ahead with this meeting, right, Sujit?
Dinner in a cosmopolitan club.
Prince, it's going to be your old den, this Calicut. So you're most welcome. I expect you to be participating in this.
Yeah, of course.
Both in the organizational part as well as the program in itself. So we'll definitely have people like Rajeev Raman and all coming for this.
Yes,
I'm
sir.
sure.
Sure.
Yeah. It was wonderful scientific session we had today.
Yes.
Let's thank our national faculty, Dr. Rajeev Raman, for finding time for us in his very busy
Thank you, sir.
schedule. Yeah, he is present in all the national conferences and international as well as a speaker, and we are honored to have him here today. Actually, we missed hearing from him about his technique of harvesting the cordyceps graft. We were discussing
In
the
Calicut,
yeah.
I will present.
You can probably demonstrate as well. We'll have real life sessions there.
Yes.
That'll be very interesting. Yeah. And let's thank all the speakers, Dr. Prince Shanavas Khan, who presented wonderfully well today, Dr. Sujith Mathew Issac, and all the delegates. We have Dr. Ajay present here, Dr. Jyoti, Dr. Joyce, Dr. Didi, Dr. Shankar Sanu. Many have already left now. I think Wisdom Trail, we had about 39 or 40 participants at one time. So it's a good number. It's a good number for a meeting like this. Schiller sir, the concluding statements from you.
Yes.
Yeah, thank you all for participating in this wisdom trail. As time passes by, this wisdom trail is getting even more popular and better thanks to Sujit. And I hope whoever are going to be the new office bearers will continue with this tradition of wisdom trail, because it's one easy method without spending too much money to get information and also exchange information.
Yes.
Especially some finer points which you might not actually get even by reading. When you talk to the experts and those, it's a wonderful idea to have this meeting. You don't have to travel. You can sit at the luxury of your home, sipping onto whatever you want, and then listen to the experts talk. So please do participate again for our next meeting as well. I'm sure Sujit and us will come out with another wonderful topic and speakers. Thank you, everybody. Good evening, a very good evening to all of you all.
Thank you. Good night.
Thank you, sir. Good night, sir.
Good night.